Hello and welcome to the webinar, Using Crisis Intervention and Prevention to Divert Individuals with OUD into Treatment and Supportive Services. Next slide, please. So your lines will be muted during the webinar. To ask a question or make a comment, please use the question and answer function, and the chat function will also be available. Please complete the evaluation in the pop-up box after the webinar to help us continue to improve your experience. Thank you. We will also have some poll questions throughout the presentation, so keep an eye out for those.
Hi, good afternoon, everyone. I'm Jody Manns. I am a project director on the Chronic and Vulnerable Populations team here at the National Academy for State Health Policy. Thanks for joining us today. We have some great speakers on deck for you, and we'll introduce them individually before they speak. But just to let you know, we have Commissioner Kimberly Boswell from the Alabama Department of Mental Health today, as well as Bernard J.B. Foster and Kassoon Peters from the Turk House in Maryland. Next slide, please. Oh, I guess we're going to go straight into the bio. I lied. Kim Boswell is the commissioner, as I said, of the Alabama Department of Mental Health. She was recently appointed just last year by Governor Kay Ivey. And Kimberly's goals include furthering accessible, interconnected, effective, and just systems of care for individuals served by the Department of Mental Health. She has years of experience and serves with us on a steering committee for NASHB. So we're glad to have her here today. Next slide, please. And then Bernard J.B. Foster, who I've had the pleasure of just meeting within the last few months, but we discovered in our research for this project a really innovative program that Bernard leads in Baltimore called the Turk House. He's the executive director there, and he's trained as a licensed clinical professional counselor. We also discovered that he completed his undergraduate degree at the same place I did, Virginia Commonwealth University here in Richmond, Virginia, where he studied psychology. So go Rams. He also completed his education at Liberty University just down the road with his degree in professional counseling, and he's currently pursuing an MBA at Regent, also here in Virginia. So lots of ties to Bernard. Next slide, please. So just to give you a little bit of a lay of the land and some background on what it is that we're doing today, we wanted to talk a little bit about how NASHB has looked at how states support opioid use disorder treatment throughout the criminal legal system. Next slide. Thanks. So just last March, we published a toolkit here at NASHB that highlights no wrong door policy approaches to overdose and SUD crisis intervention and treatment, looking at that through the lens of the correctional continuum. And some kind of stunning things that we picked out in doing that research were that 58% of inmates in local jails and 65% of those in state prisons meet diagnostic criteria for substance use disorder. We also discovered that Black Americans are 5 times more likely to face arrest for drug-related crimes despite similar levels of usage to the general population. And in doing this research, we also did a bit of a dive into incarceration and the effects that has on an individual by creating forced abstinence and thereby increasing overdose risk upon reentry, and looked at different opportunities to have interventions both pre and post incarceration to help individuals move towards treatment rather than incarceration settings. Next slide. We did this using a model that I suppose lots of folks are familiar with, the sequential intercept model that was developed by SAMHSA and partners several years back that really does map intervention points for folks with serious mental illness. And it does the same thing by looking at pre and post incarceration opportunities. So we took that and we applied that to state substance use disorder policy interventions. Next slide. Now we won't go through what all the intercepts do here. I suspect this is a model that many folks are familiar with, but it does move all the way across the continuum. Today we're going to talk about intercept 0, which is really about prevention. It's about providing community services that are designed to reduce overdose and other SUD related crises. things that pose stresses on emergency departments, on law enforcement, and finding another way to provide entrees to treatment and supports for individuals at that point. Now, the sequential intercept model does go through another 5 steps all the way to community corrections. We encourage folks to check out the toolkit that was published to learn more about those things. Like I said, today we're going to focus on community services and prevention. Next slide. So we should have our first poll popping up. There we go. So just to kind of see who's in the audience today and who is joining us, we'd love for you to select your affiliation. Just tell us where you're from, what it is that you do. There's a second question too, if you scroll down regarding applying the SIM to SUD interventions. Okay, do we have enough? There we go. Do we have enough response? There we go. So it's good to see that we have lots of state government folks with us today. We work closely with state government folks regularly, so glad to have you. And with that, we will go into our next slide, starting with Commissioner Boswell, who's going to talk to us about Alabama's crisis intervention approach. So Kim, I will turn it over to you.
Great, thank you. I'm really happy to be here today. It's really exciting to talk about some initiatives that we have going on in Alabama. But I will spend a few minutes just talking about the overall policy shift to crisis services in the mental health and substance use field, and then take a little bit deeper dive into what we're doing in Alabama. I thought it would be helpful to kind of frame the issue to talk a little bit about Mental Health America's Before Stage 4 campaign, and really everything that's being done on the national level as well as what we're doing in Alabama is designed to divert people before they reach sort of the most serious level of care. So just like you wouldn't want to wait until you were at stage 4 to get treatment for cancer, you really do want to try and do as much on the front end with early intervention and diversion before an individual with mental illness reaches the most serious level of care. And typically it takes about 10 years from the first time someone has a mental health concern or a substance use issue before they get the proper treatment. And so really, the whole policy shift nationally to crisis care is about trying to intervene early and often. Next slide, please. And I did just want to share with you the National Crisis Now 4 core elements of crisis services. One is high-tech crisis call centers, 24/7 mobile crisis stabilization programs. And then, of course, there are some essential principles and practices that support the infrastructure of crisis care, including a recovery orientation, trauma-informed care, and zero suicide initiatives. Next slide, please. So the Alabama crisis system of care that we're building out right now, it really has, sorry, my allergies are kicking in a little bit. We really have 4 major outcomes. The first is to reduce hospital emergency admissions for people who wind up getting boarded in the emergency room without their mental health needs being addressed, and also to decrease the number of jail bookings due to behavioral health crisis. And the other really important outcome for crisis diversion and crisis initiatives in our state is integrating the care for those with mental health, substance use disorder, or a co-occurring intellectual disability. And of course, one of the main goals is to decrease the rate of referral to expensive inpatient care with long lengths of stay, and really particularly diverting from a civil commitment proceeding where you may wind up in a state hospital for an extended period of time. And then we're also working to develop a regional approach to crisis care and planning collaboratively with a lot of our stakeholders. Next slide, please. So one of the most important parts of our new crisis infrastructure in Alabama is crisis diversion centers. And last year in February, right before COVID, we were able to conduct 16 stakeholder engagement meetings across the state that included law enforcement, probate judges, substance use disorder providers, just anyone who touched an individual in the mental health and substance use arena. And that really provided a tremendous amount of information for us to release a request for information to our community mental health centers and really be able to encourage them to do some strategic planning and collaborate around behavioral health crisis services. We released that RFI in May. Responses were due in July. We were very fortunate in our state that the funding that we had requested in the budget, which was $18 million total for the 3 crisis diversion centers, remained in the budget. And so we were able to issue the RFP in August and then announce those 3 crisis diversion centers that would be standing up this year. Next slide, please. So the core components of our crisis diversion centers in Alabama is 24/7 access, assessment, and linkages. We really did not have services in the community that were 24/7 services. We had outpatient services. We had crisis residential programs for the civilly committed, but we really didn't have access to 24/7 care. And so that was really critical that we stand up services that were available to people 24/7. One of the other components is temporary observation beds. And this is really important to individuals who may look like initially that they're having a mental health issue, but in fact may have a substance use issue going on. And this gives us an opportunity to assess and do observation of individuals until we can better determine what kind of care they need. We also have extended observation beds, which are 5 to 7 day length of stay. If an individual really just needs some additional treatment or needs detox services, we have 5 to 7 day observation beds that are available in the crisis diversion centers. It's also a great opportunity to collaborate with our substance use providers. If we're going to need to try and do a warm handoff to the individual who's been identified as having a substance use issue, then we have that opportunity to collaborate with those providers, as well as we have a fairly large initiative around death services in Alabama that's received some national recognition. And it also allows us to bring in those specialty providers for deaf services and services for people with intellectual disabilities. Next slide, please. The community collaborative was really critical to the work that we did with the standing up the crisis diversion centers. It was really kind of an interesting year for us, where law enforcement officials were talking about wanting to get people with mental illness out of their jails, wanting to know where they could take them to get treatment. Hospitals were talking to us, and we actually developed a collaborative with the Hospital Association to address folks being inappropriately boarded in emergency departments. And then, of course, it really gave us an opportunity. Our community collaborative allows for those specialty providers and elected officials to be engaged in their local community around crisis care and planning for crisis care and identifying the issues at the local level. Next slide, please. So this just shows you a map of Alabama, and the orange colored locations are where the crisis diversion centers are located, and they developed partnership agreements with other community mental health centers in the regions. So those are the other subcontractors, crisis diversion center subcontractors. And the regional approach is really critical in Alabama because it's a very rural state. And so those crisis diversion centers collaborated with other mental health centers to develop the regional model. Next slide, please. This year, we will be requesting an additional crisis diversion center. As it worked out last year, the 3 crisis diversion centers were in 3 out of the 4 mental health regions in the state. The blue area is region 2, and unfortunately, we did not select a crisis diversion center in that area. So we're focusing our efforts this year on region 2, and we have 5 mental health centers in that region that will be eligible to apply for the crisis diversion center that's funded in the budget this year. That's really critical because that area does cover the Birmingham Jefferson County area, which is our largest, one of our largest areas in our state. And so it's really important that we be able to build out crisis services in that area. Next slide, please. So interestingly enough, last year was a year when the Department of Mental Health received funding from the legislature that we didn't ask for, which is unheard of. But because they were so excited about addressing the mental health crisis in our state and really committed to making sure we got services out to people, the legislature actually funded 5 rural crisis projects in our state. And so they received funding to provide mobile crisis teams. Obviously in rural areas, transportation is a huge issue. And so instead of having someone come to a crisis diversion center, those programs send out a mobile crisis team 24/7 to co-respond with law enforcement and other first responders. And of course, as we talked about earlier, a big component is peer support and having people with lived experience. So as soon as that individual is assessed and they begin to get the services they need, they also get that support from a peer who can help them begin to develop recovery and get them into recovery and help share their lived experience. In addition to those services, we also have case management and respite options as well. Next slide, please. Those programs were funded at $500,000 each, and those community mental health centers, actually this year in the budget, that was originally a supplemental appropriation, but the legislature appropriated permanent funding for those 5 rural crisis projects. And really, they were doing such a great job and had done a good job communicating with the legislature that they were very supportive of continuing the funding for rural crisis projects. Next slide, please. This just is a map that shows you where the rural crisis projects are in our state. And the West Alabama, Cahaba side of the state is really critical to get those services in all of those counties because access to care for folks in those counties, it's really an issue. And so we were very excited to have the rural crisis projects. We did require the rural crisis projects to follow all of the national standards and guidelines for crisis services, just like we asked the crisis diversion centers to follow those guidelines as well. Next slide, please. So the other initiative that we developed, it is part of a national model, is the Stepping Up initiative. And again, we were trying to fund the Stepping Up initiative across the state through some existing funds. But once the legislature got involved in some work around law enforcement and individuals in prison with mental illness, when they heard about this program, they decided to appropriate additional funding so we could expand this program. The program really requires local communities to develop a proclamation and MOUs with their community partners and really begin to do the planning at the local level around services for individuals with behavioral health needs. The program provides case management in the jails. And so really, if you go back to the sequential intercept model that we talked about before, really a big part of this program is going into the jails, identifying the individuals who have been identified as having a behavioral health issue, and working with them as they come out of jail to get them the services that they need so that they don't go back to jail. And that really got the attention of our legislature, and they decided to appropriate enough funding to expand 28 more counties. Next slide, please. Through that program in 2019, you can see how many people we screened in jails and emergency departments, and then how many of those folks screened positive for serious mental illness. And then, of course, that meant that we referred all of those individuals to the community mental health center and to our substance use providers for treatment. Next slide, please. These are the outcomes for 2019. 727 were confirmed to have a serious mental illness. Of those, 186 individuals consented to receive case management services, and only 20% of the individuals who received those services were rearrested. Before that, the rearrest rate was between 40 and 50%, or that's pretty much the national average. And so we really were able to decrease the number of times an individual with mental illness is going back to jail. Next slide, please. As I mentioned before, the legislature appropriated $1.8 million to expand the program to 28 counties. And the goal is in 2 years to really expand that to all 67 counties in Alabama. We weren't as successful this year with getting the program in 28 counties because of COVID. And so we're sort of working, now that things are opening up a little bit more, kind of working at warp speed to try and make sure we get that program in as many counties as we can. Having that case manager in the jail has just made such a difference in trying to make sure people get to the right care at the right time. Next slide, please. And in closing, I just wanted to mention a couple of initiatives that we're using to try and expand our crisis care infrastructure. Some of you may be familiar with the 988 initiative that's going on at the national level. As you recall from the first slide, one of the core elements of a good crisis program is crisis call centers across the state. The 988 initiative is a national initiative to have a easy to remember, easy to access number for suicide and behavioral health crisis services. And so that's an upcoming initiative that we're working on in Alabama. And then most of our crisis services over the next 2 years, we'll look at incorporating them into the CCBHC model, the Certified Community Behavioral Health Center model, which is a model that's really gaining support nationally and also by CMS as a funding model and payment system that can really support crisis services and expansion of crisis services in the state. And CMS is also supporting 1115 authority to develop crisis services in states as well. And so that's something that we're looking at for future funding. So with that, I'll be happy to answer any questions towards the end of the presentation.
Fantastic. Thank you so much. I do have a couple of questions for you, and I can't access the Q&A, so I'm going to go ahead and put those in the chat in a bit, but we can go on to the next slide. All right, poll number 2, kind of a midway break here to gauge what folks are interested in. So that question should pop up in just a second. There we go. I think that I know you're interested in this topic because you're on the webinar, but just to gauge where you're at in terms of your work, is your state or organization currently exploring increasing crisis intervention services? All right, Josh, do we have enough responses? Well, that's an interesting split. Looks like we're about 3/4 of the way. Folks are looking at increasing or expanding those services. Lots of folks have been establishing those over the last few years. Commissioner Boswell, I was really interested to hear that your legislature did that without request. So maybe that's happening elsewhere. And I hope that we can learn a little bit more about that in the Q&A. But at this point, we'll go to the next slide. And we will turn it over to Bernard J.B. Foster to talk about Maryland's Crisis Stabilization Center. So Bernard, take it away. Bernard, you're still muted.
Oh, technology, my apologies. Thank you, Commissioner Boswell. I think you captured everything I was going to say, so I think this will probably, I don't want to belabor the point, but thank you for the presentation. It was very comprehensive. And so once again, thank you guys for inviting us to be able to present. Next slide. Oh, next slide again. So yeah, Turk House runs the Maryland Crisis Stabilization Center. And so Turk House is located in Baltimore, Maryland. Part of the impetus for really starting this initiative was that a lot of patients were presenting at the emergency department with substance-related issues. And so the state and other local stakeholders felt the need to be able to address the issue. And so one of the things they did was that they wanted to start a pilot program, and then of course, eventually be able to sort of, disseminate the programs. If it was successful, be able to disseminate the programs in other localities and counties or cities. And so I believe it was in 2018 that finally the state, local partners, local CSA, and local behavioral health authorities were able to come together to really be able to put the model together. And then, of course, a bidding war was put out, and then, of course, Turk House won the bid to be able to run the program. The essence of the program is that people who present at the emergency department, not only in the emergency department, anyone that the EMS were able to pick up from the home or on the streets, rather than overload our emergency departments, they were to be diverted to be able to come to Turk House to be able to receive treatment. Initially, the plan was that people would be able to come into the program, get stabilized for 4 hours, and within that 4 hours, they were able to get warm showers, meals, laundries done for them, see a social worker, see a nurse practitioner, and then a case manager, and then, of course, be able to either triage to other levels of care or be able to go home. And so that was the impetus for setting this program up. Part of the nexus of the program was also that we'll be able to transport patients to other programs, or if they so choose, to be able to transport them home. Sort of the model or the therapeutic model that the state and other regulatory bodies thought should happen here was that everything is patient-centered. And so really the driving force behind everything that happens here is the patient. And so, of course, with other professionals working in conjunction with the patient was the one, really driving what needed to happen. So if the patient needed to be triaged home, then that was exactly what happened with other outpatient services to boot. But really, essentially, it is a patient driven model for the patient to be able to, dictate what happened with their treatment. Next slide. Once again, I think I've already touched on this, but the impetus for really putting this together, Baltimore City has been hit over the years with substance use and other behavioral health related issues. And so I believe in 2017 or thereabouts, I believe the data on the hospitals for people presenting at the emergency department for just substance related issues at Baltimore City was about 11,000. And I think one of the things that was happening with the hospitals was that when patients repeatedly reported to the emergency department within a certain time frame, the hospitals were not getting paid. And so immediately, there had to be some decisions made very quickly as to how we could really serve the patient, where they were not just showing up at the emergency department, but more so they were really getting the essential services that they needed. And so that was what prompted stakeholders, state, local, and state, to be able to come together and really put this together. And so that is the impetus for this program really coming together. Next slide. And so, of course, as you can tell, the partners that were really essential to actually us being able to open in 2018 was, of course, our local health authority, city emergency medical services, crisis response teams, of course, Turkhouse. And one of the ones that I cannot emphasize enough is our local community. One of the challenges we have in Maryland, we have something called NIMBY. I don't know whether you guys have it in your areas, but it's called Not in My Backyard. And so the local community were really one of the first driving forces to having this actually come to fruition. And so in the Baltimore City area, we had, especially from the Turkhouse side, we had the state and the local health authorities actually flew local communities to places like California and other places to really look at what they were doing before we could even have their buy-in. And so after they were able to go to places like California, San Francisco, and other cities in California, they were able to come back with their blessings and their sort of endorsement. And so once that happened, then of course, I think we were able to really put this program out for everybody to be able to access. Next slide, please. Twofold. It's from the community, number one, and then from the state. And so we have one from the community, and then we have one from the state. As I think Ms. Boswell put it quite succinctly, we are working with CMS to try to see from a sustainability standpoint how we can partner with them to be able to really make sure that this program is sustainable. And so currently, in as much as be able to really sustain this program beyond the other funding sources. Next slide, please. And just a few, we didn't want to overload and bombard, at least for this webinar, a lot of data points. But really, one of the glaring outcomes for this pilot over the last 3 years is that we've had success rate of 80% referral to other treatment programs. One of the good things with Turkhouse winning the RFP to be able to run the program was that we also had other levels of care that could also assist in treating the patient and also with the triage mechanism. But 80% so far have been able to be linked to other levels of care and other treatment providers to continue with treatment. Another thing that another impact positively has been reduced medical utilization. Patients presenting, of course, at the emergency department, the number there has come down quite drastically, reduced medical cost, reduced, of course, medical visit, and of course, overall, improved quality of life. If people want more data points, we'll be more than happy to provide them. But we felt that for the purpose of this webinar, we keep it to these few points. Next slide. The future of the Crisis Stabilization Center. And so one of the things we want to be able to do is to be able to address the social determinants of health. Of course, of which housing, food, mental health, employment, and education form the basis of. We want to be able to really address recidivism rates. And so I think the way we can do that, at least from this neck of the wood, is to be able to address the social determinants of health, employment, other treatment services, housing, and of course, certainly education as well. And so really, if we are able to address social determinants of health, then I think we'll be able to mitigate a lot of the challenges that we see in the behavioral health arena. And so that is the ultimate goal for state and local, and of course, Turkhouse as well. Next slide. I guess we are through. Once again, thank you for the opportunity to present. I'm quite sure if there are questions that needs answering, we'll be more than likely and more than happy to be able to do it. Thank you so much.
Absolutely. Thank you so much, too. We do have, I can see we have one question in the chat, and I have a couple that I can't put in the Q&A. So I'm going to send those to Eliza, who I think is going to go ahead and facilitate questions for us. Eliza?
Thank you, Jody. Hopefully people can hear me. The internet is not great in Baltimore at the moment. We do have a question for Commissioner Boswell. Question is, what will the ongoing sources of funding be to maintain the crisis intervention observation beds?
The current funding for crisis diversion centers and those beds that I described as state funding, and that's a continuing appropriation. And so the state actually committed $18 million to that effort. And we do plan to add another crisis diversion center this year. And so far that's remained in the budget, and potentially 3 next year. To help us go statewide though, it really is going to take looking at the CCBHC model and potentially 1115 authority to get us to a place of statewideness with crisis services. But they funded pilots, and they are still very supportive of funding additional crisis diversion centers over the next couple of years.
Great, thank you. And this is for the Turkhouse. How has COVID affected service delivery for you guys?
Oh boy. So I guess it would be nice for me to give context. So Turkhouse, the Stabilization Center is currently 35 beds. It's a 35-bed program. And then Turkhouse also operates an 82-bed inpatient treatment facility as well. And so, of course, just for context, because of COVID, we had to reduce the crisis beds to 17. And unfortunately, in as much as patients needed treatment because of the social distancing mechanisms and all these other things we had to employ, we had to almost cut the numbers by half. We did the same thing on the inpatient side, where we reduced our capacity to about 50%. But that was, we've recently in the last quarter been able to kind of reamp with vaccinations going on. And then of course, Turkhouse, one of the things we've done is every week we are testing our patients and employees. And so we are able to ascertain immediately what the needs are. And because we have a higher level treatment team, nurse practitioners, medical doctors, social workers, peers, and the like, we are able to absorb a lot of the issues that may come up with respect to whether it's somatic or behavioral in nature. And so that is how we were impacted. We've just recently attempted to re-up the numbers, especially on the crisis stabilization center side. We've moved from 17 beds to about 20. We are trying to do things gradually under the advice of our medical director. And so that is what we are doing at this point.
Thank you for sharing, and I'm glad that things are slowly inching back towards normal. That's good to hear. Commissioner Boswell, question for you. What was the impetus from your legislature to fund crisis services without that funding being requested? Was there an event that occurred or something that they saw in your mental health data that brought about that request?
So one of the things that happened, particularly with the stepping up model, the legislature, the governors established a task force related to our prison lawsuit. So we have a huge lawsuit going on in our state around prison overcrowding and health and mental health services, or the lack of health and mental health services in our state prisons. And so that task force asked former Commissioner Bashir to come and present on the Stepping Up initiative. And honestly, I think they were just so overwhelmed by the enormity of the issue within the prisons that once she did the presentation and explained that sort of what we're trying to do is keep people from continuing to go to jail over and over and eventually winding up in the prisons, I think they just wanted a program that they felt like could make a difference right now. And so it was like the prison overcrowding and all those issues. It was just such a huge issue. And I feel like Stepping Up wound up being the thing that they could say, okay, right now we're going to do this for a little bit of money. At least we know we'll be keeping people out of jail. We may not be able to do anything immediately about this big prison problem we have, but at least we can fund a program that will try to keep people not only from continuing to go to jail, but also try and keep them long-term out of prison. With our rural crisis model, there was such a groundswell of interest around mental health in the past legislative session because you had a couple of legislative leaders that had personal experiences that really influenced how they looked at the mental health issue. One who lost a good friend to suicide, and a couple of other sort of similar scenarios. And really, as we began to talk about the crisis diversion centers, it became obvious that the community mental health centers, the larger community mental health centers in the more urban areas, would be able to compete for the RFP more so than the rural areas. And so we had 2 or 3 members of the legislature from rural areas that said, look, we need some crisis services in our area, and let's fund a rural model in some counties in Alabama. And so it was really, it almost got to be, we were sort of, everybody was competing to see who was going to get the most mental health services. It was just really an unusual experience. I've been around state government a long time. One, it's very unusual for members of the legislature to put money in your budget you didn't ask for, but it's also very unusual to have the executive branch, the legislative branch, kind of all on board with, we need to do something about mental health. And sort of the divine intervention of that was crisis care was something they understood, could easily understand, and could immediately fund and feel like their local sheriff or their local probate judge would be on board with it. And so it was just a very unusual, I mean, we couldn't have planned it that way if we tried. It was just a lot of really people's just dedication to and commitment to addressing the crisis in mental health care in our state.
Yeah, it sounds like a lot of factors came together and to a head all at once and kind of created the perfect storm for that. But it's really encouraging to hear that, and hopefully you guys will continue in that direction. I have a question now for Bernard and the Turk House. Bernard, what did you learn from other states and programs as you were developing this approach? And do you have any advice you would give to others who want to create a similar kind of program or take this similar kind of approach?
Oh, that's a great question. I think for us, one of the states that we visited to be able to really establish this, one was in San Francisco. I think San Francisco, actually California, was one of the first states that really started looking at this sort of model as a way to be able to treat patients. And so we visited California. We had meetings with some of the team, the provider teams over there, to be able to get a sense as to how to be able to do this. Of course, we also did go to Texas as well. San Antonio, I believe, and Houston also had a model similar to ours, especially the one in Houston, San Antonio, because they also had other levels of care. The state actually and other local stakeholders also actually went there first to be able to get a sense as to what needed to be done. And so after all these visitations, we were able to put our heads together to be able to actually execute. I think one of the advices I would give is we have to advocate. We have to be in that advocacy arena to be able to really let state legislatures know, we have a problem on our hands, and it's not a problem that we cannot treat, but we just need the assistance and the funding to be able to address a lot of the needs of our communities. And I think if we can become advocates for our communities and of course our patients, then I think we would be able to really not necessarily bend, but really influence legislation to be able to really address these needs. In Maryland alone, one of the things that we saw going up was overdose-related deaths. In the year when we really, I think, opened this program, the prior year, we had lost about 2,000 people to overdose-related deaths. Almost 40% came from Baltimore City. And so it was sort of a no-brainer to really be able to really address this issue. And so I think the advocacy channel is one area where we can get this done. And then of course, since we are a nonprofit, I saw on Commissioner Boswell's presentation where they are now looking to address the 1115 IMD waiver. We already got it passed, I believe, in 2017. And so now gone with it is where everything was sort of grant funded for us. Now we have CMS on board funding, residential substance abuse treatment facilities from the ages of 18 up. And so that has also helped other nonprofits to actually really start innovative programs without necessarily the blessing of state and local authorities. However, especially for the stabilization centers, we really needed the state and the local had to come together to really put that together. We just happened to be the program that won the bid to run it. And so I think advocacy and also looking at other methodologies to be able to do it. Looking at the foundation community is also another way to go ahead and be able to do it. A lot of these local foundations are looking to also fund such projects. And so looking to partner up with them also would go a long way to be able to mitigate such a humongous problem that we have on our hands. So yes, so that's what I'll say to that.
Thank you. Thank you for that response and all of those suggestions. Another question I think probably both speakers can respond to. Is there a discussion for funding the CAPTA or the Comprehensive Addiction and Recovery Act federal mandate for plans of safe care for substance exposed infants and their families, as this could be a tool to manage the opioid crisis?
I'll defer to Ms. Boswell first, and then I can chime in.
We haven't really looked at that carefully. We're not at this point looking at that. To my knowledge, we've had so many things going on in the American Rescue Act and other things coming at us, but really are trying to work out an expansion of family services and a comprehensive on the substance use side, and really just expanding what we do for families and family intervention, and just kind of building that from the ground up.
I think it's the same way over here too with Maryland, albeit one of the things that Maryland has done, we have programs that address mother and child. And so in substance, and so we have residential programs that really address, children and their parents, especially mothers. And so looking to expand that from the legislature side of things, but nothing has come to fruition yet. But there are conversations going on currently between state stakeholders and local addiction and mental health CSAs and organizations. And so currently we do have the mother and child dynamic going on already, but we are looking to expand that, but nothing has been fleshed out just yet.
Great, thank you both. Another question for both of you. So initial programmatic outcomes are looking good for both of your states. Is your state or both of your states seeing any savings because of these outcomes yet? And if so, how are those savings being used?
So that's a broad question. The state, in as much as I think this program has been very crucial for the state, I think from the Turkhouse side, one of the things we have used to be able to detect reductions in cost or cost savings for patients in the state has been using the CRISP model. And so we're able to really go through CRISP and be able to figure out, and maybe Kisan, if he's on, can touch on this, we're able to figure out when patients access treatment, we're able to tell from the dates they access treatment and how often they went back, especially to the emergency department, or how often they didn't go back. And so that is what we have been used to, at least from the Turkhouse side, to capture some of the cost savings. And so that when we are talking to the state, we're able to really cite these data points. However, I don't think from the state's level, that is something that they are working on, but nothing has been established to the degree that I'll be able to comment on. But I think from us, from the Turkhouse side, we're able to report on, okay, if patient A has been accessing the emergency departments for substance-related issues, once they access the Crisis Stabilization Center, we're able to see from the CRIF system whether they've been going back to the emergency department, and we're able to report on those data points and we are also able to associate dollar figures to them. And so when we are talking to state regulators, that is sort of some of the data points we are citing and coding for them, so that at least these programs could be funded in budgets, state budgets. And so that is what I can speak to.
And in Alabama, the crisis diversion centers are standing up this year, and so they'll begin providing services May 1st. And so we don't really have any data from the crisis diversion centers yet. We do have obviously some data from Stepping Up and the rural crisis models. But our dilemma, and one of the things that we've been working on, is with our hospital association and trying to get better data and data sharing agreements with the hospital association, because it's hard for us to know whether or not folks are continuing to cycle through emergency departments, private psychiatric beds in the community. So we really don't have a lot of good data yet. What we did accomplish this year, the legislature passed a law that requires the hospitals to report certain data, and the hospital association was on board with that. And so we hope through our partnership with our state hospital association that we'll have better data to show that people are not taking up more expensive beds, and that people are not spending as much time in jail. But those cost savings are for the jails and for the hospitals. We are not sure yet how it's going to impact. Hopefully our waiting list for our state hospitals is sort of the other underlying objective. We're hoping that we can decrease the waiting list for our state hospitals as well, which would be a huge cost savings. Obviously, if we can get people into a lesser restrictive level of care, then that's less expensive than having them eventually wind up in the state hospital bed. And so it's so new in our state, we really don't have good data yet to say whether or not we have the cost savings that we were hoping for.
A little addition to, I think the challenge Ms. Boswell was articulating. What we've done at Turkhouse is we've bypassed, the state, and we just entered into a partnership with Maryland CRISP so that we bypass the hospitals. And so we just entered into a partnership with Maryland CRISP where we are getting these data points are readily available for us to be able to access. And so that is what we've done. And that is how we are able to kind of get these dollar figures on cost savings back to the state.
Thank you both. I think data sharing is a recurring and significant problem for most states and organizations within states, just in terms of the risks associated with sharing these data, especially extra protected data. So thank you both for sharing successes and continuing challenges. Bernard, I know you have a hard stop at 2, but one quick question for you. Can you talk about whether you guys accept patients outside of Baltimore City? And I know you spoke about how excellent the community has been, but I'm sure you do experience some of that NIMBYism to an extent. So if you can speak to how you address that briefly, that would be great.
So Turkhouse has been a fixture in the community for 50 years. And so we are sort of a known commodity. And one of the things we've done is, ever since we've been in the community, there's a monthly community meeting. And so we make it a point to attend those meetings. We brief the community. We are able to answer whatever challenges and problems they may have. In fact, right before we opened the Crisis Stabilization Center, one of the key points that the community made it a point to emphasize on was that they didn't want people hanging around the community. And so they had this idea that, especially, if you go to methadone clinics where people are lining up, and so they had that type of setup. They have that type of idea that once we opened this program, that was what was going to be happening. Fortunately, that is not what the Crisis Stabilization Center is about. And so a lot of the partnership have gone to the degree that we haven't had any problems with the community, our local community. And then, of course, even when we have challenges, they have my personal number. And so they're able to reach out to me and call me directly and be able to articulate to me and express challenges they are having. And then once I address them, I'm able to also go back to them and make sure that they are satisfied. Not only that, one of the things prior to our opening the program was for us to open the employment process to the community first, so that the community felt that they had a vested interest in what was going on, in that they were able to actually, for those that could, work in the facility. And so I think the relationship with the community, even prior to the Stabilization Center opening, was already in existence. And so this was, they see this of course as an added help to be able to access, open access for treatment. And so they've been very supportive of what we do. And then of course, like I said before, if there are any challenges, they are able to reach out almost immediately. And then almost immediately we will resolve it, coupled with the monthly meetings that we attend with other stakeholders to be able to address any concerns they may have.
That's great to hear. Oop, stop, sorry, that was my timer. That's great to hear. That's a great note to end on, because I think both of you touched a bit on community response and stakeholder engagement. And unfortunately, there is still some sense of stigma and such as a part of this conversation, but this has been fantastic. Thank you both for your presentations, as well as for allowing us to pick your brains. Slides and the presentation will be posted and will be shared with folks. If you have further questions that we didn't get to, please feel free to email me or any of my colleagues at NASHB, and we will make sure that those get answered. We do have an evaluation question about to pop up. I know folks have 2 o'clocks to get to, so thank you very much.
And Jody, can I add this?
Yeah, please.
Over 18% of the patients that report to the stabilization center are out of state, out of the city. They don't come from Baltimore City. And then we have sometimes out of state people who come through the city for fun, and then things happen and they show up. So just wanted to add that, but thank you so much.
Thank you. Take care.
You too.
Thank you, guys.
Thank you, Ms. Boswell, troublemaker.
Good to meet you.